to reconnect with all my friends and seniors here. So I'm going to talk about first-line chemotherapy, regime schedules, adverse events, and compliance and efficacy for lung cancer. Non-small cell lung cancer, this is the history of therapy, of the way the lung cancer therapy has been evolved. Since 1970s, the median survival was 2.4 months, which has gradually increased to around 18 months. So the therapy is based on histological types. For non-small cell, it's adenocarcinoma, squamous, small cell, and undifferentiated. So preferred regime for non-squamous is an adjuvant setting is cisplatin and pemetrexed. That's every 21 days for 4 cycles. For selected population of age more than 60 with 2 or more comorbidities and with low albumin, they may need a primary GCSF prophylaxis. Now this data, we have it as it has been known from this TREAT study that adjuvant chemotherapy with cis-pem is safe and feasible and is less toxic as compared to cis-vinorelibine from the LACE meta-analysis, which was standard of care back then. The adverse events that we see across is mucositis, neutropenia, pleural effusion, nephrotoxicity, and ototoxicity. Mucositis is prevented by giving pemetrexed in the required infusion time of exactly 20 minutes. Neutropenia is circumvented by continuing folic acid supplementation. Pleural effusion, if any, has to be tapped because the pemetrexed gets accumulated in the third spaces. For squamous, the preferred regimen is cisplatin and gemcitabine, 75 mg per meter square and 1250 mg per meter square, day 1, day 8, every 21 days for 4 cycles. Toxicity against here are neutropenia, mucositis, diarrhea, CIPN, and nephrotoxicity. Other recommendations are cis-vinorelibine. Now, this again, cisplatin 50 mg, day 1, day 8, and vinorelibine, day 1, day 8, 15. That showed an increase in OS and hazard, improvement in the hazard ratio for death, and increased relapse-free survival. The 5-year survival rate was 69 and 54%. Similarly, we had this ANITA trial, which used cisplatin 100 mg on day 1 and vinorelibine same way for 28 days cycle. So chemotherapy regimes for patients with comorbidities or patients not able to tolerate cisplatin, these groups includes people with low ejection fraction less than 50 or create clearance less than 50. We can use carboplatin AUC6 with paclitaxel 200 mg per meter square on day 1 every 21 days for 4 cycles. Or carboplatin can be used with gemcitabine too. The least toxic among all is carboplatin and pemetrexed in non-squamous parts. Bevacizumab can be added to paclitaxel carboplatin, where we have increase in 1-year OS at 51% versus 44%. The indications for bevacizumab are non-squamous and non-squamous histology. For advanced stage, again, that is PEM carbo, that is AUC5 and pemetrexed 500 mg per meter square. The other regimes are albumin-bound paclitaxel, carbodosi, and carbogemcitabine. Albumin-bound paclitaxel can be substituted for either paclitaxel or docetaxel, who have hypersensitivity reactions receiving pacli or dosi, and pre-medications for patient where standard medications are contraindicated. For small cell carcinoma, for squamous cell carcinoma, preferred is carboplatin with albumin paclitaxel, carbogem, and carbopacli again. Maintenance therapy is continuation of therapy beyond 4 to 6 cycles, and switch maintenance is addition another agent after completion of 4 cycles. So the continuation can be either bevacizumab, pemetrexed, or bev pemetrexed and pembrolizumab. Switch maintenance is pemetrexed here. Thank you for your patient listening. Yeah.
Thank you, Dr. Avinash.